Welcome, friends, to the Clinical Education Academy. I chose an important topic for you in general surgery today, and that's the pilonidal sinus, or we rather should call it pilonidal disease, because it could present in basically two ways. It's either an acute abscess formation or a chronic discharging sinus. The problem is relatively common, and we need to know how it presents and what sort of treatment and advice we could do to the patients. It's a common condition, particularly in young men. Sorry for that. Particularly in men with coarse hair. So it is an inflammatory, defined as an inflammatory / infective condition that affect the lower end of the back in the sacrococcygeal region. It's particularly common in the Mediterranean basin, where more people have hairy body, or they are genetically kind of hirsute. So what happens is that it's chronic inflammation of the hair follicle. And as a result of the chronic inflammatory process, the hair can get dragged down deeply into the subcutaneous tissues in the region until it reaches close to the sacrococcygeal fascia. And occasionally, as a result of that and of the inflammation and the presence of the hair as a foreign body, it will lead to infective exacerbation and abscess formation. So here, in particular, perpetuate the process of inflammation. And there are other theories that because the area is moist and also it collects fluff from the clothes or hair or fallen hair, then these cracks can become inflamed and they drag the hair with them down into the wound, which will lead to chronic infection and discharge from the area. The way this disease presents, as I mentioned, we need to know that it is basically it presents in two different situations. One of them is the acute exacerbation or abscess formation, and that presents suddenly as a sudden onset of pain, swelling, and redness. Patients feel unwell and they might have temperature. So all the signs of systemic inflammatory response. And the other form is chronic discharging sinus, and that means that there is one or more than one sinus that communicate deeply into the area where the infection and the hairs are causing the inflammation, and it will discharge a purulent material, usually associated with blood and some discomfort, but there will be no acute pain. Now, with this in mind, we will need to go over the management. What do we do if we get an acute exacerbation abscess formation? The process of management here is essentially no different from an abscess anywhere else in the body. We will start them on a broad spectrum antibiotics, usually in the form of amoxicillin plus carbonic acid, or second generation cephalosporins, or anti-staphylococcal, other anti-staphylococcal medications such as kefazole intravenously. Often the organisms that lead to acute exacerbation is Staph aureus, but it could as well be other forms of bacteria in the form of gram-negative bacteria. We take the patient to the operating theater, and under general anesthesia, we drain the abscess. We prefer the line of the incision to be off, or the cut will be perpendicular on the abscess, but it will be off the midline, and that will facilitate the healing process. Off the midline incisions heal better than midline incisions. So we remove the pus and we wash the area and we pack it with a seaweed product called Caltostat. The wound will be left open and need to be addressed on daily basis, usually for at least the first week, and then that can be reduced down to twice weekly. And it will take the wound somewhere between 3 to 6 weeks to heal. Alternatively, if the wound is significant, we could manage it with a vacuum dressing. A small vacuum machine that the patient will carry and take home, and it will stay in there for at least a week before it needs to get changed. And district nurse will follow that up and change the dressing for them, which means that they will have less frequent dressing. Also, it will reduce the pain on an ongoing basis, and also the pain and the discomfort during the change of dressing. And a vacuum dressing is universal now in general surgery and wound management, and can be used for a variety of wounds, including an open wound for a pilonidal abscess or pilonidal sinus. Usually advise the patients to do hair removal using a specific cream for the first 6 to 8 weeks after the operation, regardless of the type of the operation. Whatever we do, there will be a chance of recurrence. You need to warn the patient that their chance of having another episode of acute or chronic inflammation, and that's high and sits at about 25% of the cases. The other form of presentation of the Pilonidal disease is it can present in the form of a chronic sinus. And the chronic sinus, as I said, it could be one or more than single orifice of discharging purulent material associated with the blood and discomfort. Now, there are a variety of methods of treating the non-acutely inflamed or just a chronic sinus for pilonidal disease. If the disease is mild, you could just leave it, and a lot of them will heal without any surgical intervention. But if they need surgery, we could manage them in a variety of ways. One of them, the simplest way, is to curate the sinus area, leave it open, and do packing or vacuum dressing until it heals. This is the simplest and the oldest form, and the only disadvantage is that it will need dressing and wound care for the first 3 to 6 weeks. If the wound is simple and there is no acute infective process, then we could do a simple excision and primary closure. And when we excise the pilonidal disease, we have to be radical to cut down all the skin and subcutaneous tissue that's involved with the inflammatory process down to the fascia, and then we close the fascia and leave a suction drainage for 48 hours, and we close the skin off the midline. This is the classical form of what's called the Bascom flap and or Bascom repair, and it is a proven method to expedite healing. There will be a chance that the wound could get infected and fall apart, and in that case we revert back to dressing and packing. Marsupialization is another way, but it's not very popular, which means that we curate the area and suture the skin down to the fascia on either side and leave the middle part open. It might expedite the healing, but it's a more complex procedure than the simple excision. There are a variety of flaps that can be done. The simplest is the Bascom, which doesn't need any mobilization, or the Karydakis, which means that the gluteal area will need to be undermined at the subcutaneous fat and facial tissue and moved to close it off the midline. Another form of flap is the rhomboid flap and the Limburg flap, and these will only be indicated in a complex recurrent pilonidal disease. Generally, I prefer the bascom or the Karydakis closure and try to avoid the flap formation because the risk of failure is significant, and if it fails, then the problem is that you will end up with a very wide open area that need to be have vacuum dressing for a few months before it settles down. So we try to avoid those unless the disease is so complex and requires some form of flap. Otherwise, it's always either an open management or a simple closure with a bascom or a Karydakis type of closure, where the skin incision and the skin closure will be off the midline to avoid the wet area that in this situation will promote the healing process. Thank you for staying with me, and hopefully this has informed you about how we deal with the pilonidal disease in general. We will leave the surgical techniques aside at this stage. And hopefully I will see you in the next video.